You ever wonder why your joints ache more at certain times? The secret could be in your hormones. Discover how hormonal changes might be fueling your joint pain and what you can do about it. Welcome. Today we have with us Dr. David Gallegos, a naturopathic medical doctor, and we're going to talk about why you may be having joint pains all of a sudden, and it may be the root cause is your hormones. Welcome, Dr. Gallegos.
Thank you for having me. It's a pleasure.
So please tell us a little bit about you. Why should these listeners listen to you? What are your quals?
Yeah, so I am a naturopathic medical doctor. I had my undergrad at U of A here in Tucson, where I studied microbiology and Spanish interpretation and translation. And so that really gave me a good background of science and really what it is in terms of being able to have a solid science background, but also develop my social and my linguistic skills especially in the Spanish, more specialized sort of learning in terms of medical and legal terminology. And so that really gave me that great foundation to now I see it and I use it every day with my patients. But after that, I wanted always to be in the medical field. I didn't know really if it was nursing or physical or personal training or whatever it was, but I knew that I wanted to do something in the medical field. But after I graduated, I was applying to PA programs, but then I stumbled upon the naturopathic degree or naturopathic program here in Tempe.
Okay.
And so I really fell in love with the curriculum, the fact that we can have a lot of different tools under our belt that really can provide that extra level of care to our patients and really that personalized care that they really need, especially within the primary care world. And so once I saw that and once I saw the curriculum, I just knew that that's what I wanted to do and pursue. So I started and then I graduated in 2019, 4 years later. And then I really, through my training, I became really focused in pain management and longevity. And so now that's what I do here in my practice, really looking at longevity in patients and the health span and the lifespan in general of our patients. So
those are quite the buzzwords right now, health span and lifespan.
Yeah.
I know that a lot of patients come to me and they are on some form of bioidentical hormones. That's what we're talking about here, isn't it?
Yeah, no, absolutely. And I think it's so important to really educate our listeners and our viewers to know and identify really the relationship between hormones and the potential of your pain, whether it's chronic or acute pain. I mean, there's so much data, so much information out there linking the relationship between the decline of these hormones as we age and the potential relationship with your current pain status. And so I think that's so important to have that discussion and to really educate our patients about.
And we're talking about males and females. I mean, you already knows that there's menopause, that as a woman starts to reach a certain age that we get a decline. Can we start with females and then we'll talk about andropause, or the funny, little quirky term, people call it monopause, but really it's but let's start with the women. We have so many people who come in, like I've had women who say it's like almost night and day. They just started waking up and absolutely everything ached. Some of them were even given a diagnosis of fibromyalgia about that time, or they said that they had no energy, they have fatigue, they have brain fog, they have all these things. Like, I should be in the most vibrant time of my life. The kids are now coop. I'm now ready to have this wonderful second life, second part of my career, second part with my husband or my partner, and I just don't have the energy. So can we start with the woman?
Absolutely. Yeah. I mean, I think you get a lot of points there that are super valid. Knowing that there is a potential risk as we age with our decline of hormones in females, we already know that postmenopausal or menopausal females have a higher risk of developing osteoporosis, osteopenia. You're already going to have issues with that just by being menopausal, but also the increased risk of Alzheimer's, dementias, and pain and fatigue and weight gain. So yeah, the relationship is there and we already know. I mean, our hormones in females start declining after or as early as our 30s, 35s. But some people, to your point, they go through that change at different times in their lives. So I think lately, I've also been experiencing a lot more early onset menopause on females. Before it was in the 50s, 52, but now I'm seeing as young as 39, 38-year-olds are going through, and we can really show that with our lab work that they're truly in that perimenopause, menopausal state. So it's so crucial to really know where you are, where your hormones are. And so if you do have a complaint up to your point, body aches and fatigue, weight gain, and all of these things, then nobody seems to be able to find that root cause of the issue. Potentially, not to say that everything is hormones, but there could be a relationship there with where your hormones at, and that could be potentially the cause of your knee pain and your ankle pain, your hip pain. And so I think early detection and early testing can never hurt. If you have, let's just run a simple blood test that's going to really tell us a lot of information about your hormones, where you are in your cycle, if you're still having a cycle. And then based on that, we can discuss about our options. And it's also important to know the options that are out there for female and for really anyone. Is it bioidentical hormones, or is it synthetic hormone replacement, where we're talking about the equine-derived estrogens or progestins? And those are the things that could come with an increased risk of certain diseases. And so trying and understanding where you are and what's a better treatment option for you is really important to know. So
to those amazing points you just made, here's where I think that naturopathic medical doctors can absolutely distinguish themselves. Oftentimes when women go to their traditional Western DOMD, the blood test is going to be a little bit different. I mean, if it's not this one test, then you're not in it. Don't worry about it. Come back and see me in 4 or 5 more years when you're actually having so many hot flashes that you can't sleep and you're waking up in sweats. So can you tell me a little bit in a sentence or two how you're different, how things, and maybe even if it's a test it's different, or the timing of the test?
No, that's great. Yeah. So usually for my testing, if they're still having a cycle and a regular cycle, then I usually always like to test it in the luteal side, which is the later side of the cycle, which we're really going to be able to pinpoint and identify true progesterone deficiency. And so that to me is one of the first ones that I like to identify. If I already know the patient maybe is going to be more estrogen deficient or even estrogen excess, then maybe I can test it in the follicular side or follicular state. So more around 4 to 6 days after the cycle. But yeah, to your point, that's so important because I've had so many patients that come to me and they say, well, I got my hormones tested a few months ago. And I ask them, well, when did you test them, or when did you get them tested in your cycle? And either don't know, or they told them it doesn't matter, and we just need to test them. But going back to the type of test, for me, still a blood test is the best way to test. There's some other labs out there that say urine or saliva or hair. I just don't know that the data really is there to support a lot of those tests. And they could be there, it could be developing, but I think still blood is, in my opinion, the best way to test those.
So how about those? I know there are a lot of people who take continuous birth control, or have an IUD, or they're not menstruating. And so they're not quite sure when they've crossed over into the menopause or their perimenopausal. Anything special for them?
Yeah, I mean, with oral contraceptives, it's tough because a lot of them are already taking some of these hormones. So am I really going to be getting a physiologic test result of where you are, or is it going to be more of what you're orally or patch or whatever it is that you're taking? And so for that, just having that conversation of why are you on birth control? Is it because of I had a heavy period and painful period and then they just threw birth control at me? Or is it because you're truly using it for contraceptive measures? And so that really helps the patient and guide him through, okay, well, is it maybe time for me to get off of that because I'm no longer needing this for that time or that measure that I was first prescribed to. If it's the IUD, same thing. It's a little more targeted toward the reproductive organ, especially if they're having a copper IUD. It's a little bit better because we know that they're still going to be secreting some other physiologic level of hormones. So it's a little bit better to test and to still provide a sense of treatment on those patients, still with the cautious measures and make sure that we're not, oversaturating the patient in terms of the dosing. But yeah, it's not that they can't be on a bioidentical hormone replacement. It's just that maybe we can start with maybe a testosterone until we work on maybe getting you off of these other measures until we see where your true levels are. And then maybe we can start talking about, progesterone and estrogen.
Wonderful. Thank you so much for breaking that down. So let's say we do know that a person is in menopause or perimenopausal, and they've got all these complaints. Let's hone in down. We both do pain management. We both do musculoskeletal medicine. Let's hone in on, they've had some films, they've had an evaluation, maybe even by a sports med doc. They're not really seeing this crazy degree of osteoarthritis in the knee, and it still hurts so bad. It's achy. It's in the morning. That makes you think it's AM pain, maybe OA related, arthritis related. How would you approach that? Because maybe there's grade 1 or grade 2 osteoarthritis, but above and beyond what you'd normally think it is. And you've ruled out it's not a meniscus tear. You've ruled out it's nothing like a patellofemoral pain syndrome and it's an alignment. How do you kind of approach that? And then what do you start to see and how early? Like, give me on hormonal, when am I going to start to see the benefit?
Yeah, I mean, I think it's one of the things that I usually always recommend to patients is looking at their hormones, because I've had so many patients that come with multiple joint pain. They've seen rheumatology even. They've seen multiple specialties. To your point, they can't find anything that they can diagnose them with. They just give them NSAIDs to the max, but we're not targeting what the root cause of the issue is. So going back to that hormone replacement component of it, we know, for example, in estrogens, that there's tons of receptors in the joints, in the bone, in the cartilage, in tendons, ligaments. And so as those levels keep going down as we age, those receptors are not going to be saturated enough. And so, yeah, absolutely, you could have almost a post-hormone decline reactive effect of that hormone piece that is not being looked at. And so 100% of the time, as a naturopath, finding the root cause is so important. That's our ingrained philosophy. And so not only hormones, but also your environment factors, your stress levels, your diet and nutrition, your sleep. All of these components really do play such a major role into that sort of vague, undiagnosed patient that comes into our doors that was frustrated, unfortunately, because they just don't have any answers. They've tried steroids, they've tried this, they've tried that, and nothing seems to be sticking and nothing seems to be working. And so I think really looking at the patient as a whole and given that time and that proper evaluation, it's so important. And I think every provider, regardless of your specialty, it should be on the back of your mind. It shouldn't be a thing that I don't really know what's going on. Take some painkillers and let's see if that helps. Or it's frustrating.
And then we get ladies who they're in their 60s and they've not been on anything for 20 years and they could have potentially been benefiting this whole time. Is it too late at some point?
For hormone replacement, if anyone has had a postmenopausal state of not having an actual period for more than 10 years, I don't recommend an estrogen replacement, because usually by that time, your endothelial in your artery walls are to be maybe a different state, maybe more fragile. And so there is a potential increased risk of some blood clots and some other issues that could arise, especially with an estrogen replacement. But also depends on type of replacement. Maybe if they absolutely think that they need it and they can actually benefit, then maybe starting with a low dose cream that we know where it's going to be the safest way to give a patient estrogen replacement. But always looking at everything and looking at the metabolites. One of the things that I hear every day with my patients with estrogen or really with replacement, is it going to give me cancer? Is it going to give me breast cancer? And so I always tell them it's not the actual therapy and the replacement that increase the risk of breast cancer, especially, but it's more of the byproducts and the metabolites of this hormone that could potentially increase the proliferation of tissue, so the growth of tissue, especially breast tissue. So it's always super important to look at all the risks and the benefits to every case and every patient. And if they are at an increased risk, then we have to be super careful if they do want to go. And I think that the benefit surpasses the risk of estrogen replacement. Maybe we have to follow it up with a more specialty testing and look at, well, what is that molecule doing once we give it to you? Is it metabolizing in an estrogen receptor alpha, which is known to be more inflammatory, more of that proliferative state of your breast tissue, or is it going more toward the beta, right, which is more of that beneficial and that healthy type of metabolite? And so those things are super important, and I hope that people that are listening to us, it's not being deterred by the risk of breast cancer and the risk of estrogen, because we can really pinpoint and we can really identify your true risk with the development of all this a new level of testing that's really out in our fingertips that wasn't maybe available 10, 20, 30 years ago. So it's so great that we can have access to those things now, and we can really use it for our patients.
Completely.
So
Absolutely. And I think we can talk a little bit about there are different ways of putting. You talked about a cream. You talked about, I know that some people get pellets, some people get troches, some people get all these things. Specifically, though, we are distinguishing on people placing intravaginal, which is more for the vaginal tissue and the likelihood of having systemic absorption and helping the joints. Can you speak to that briefly about it's a different monster?
yeah, absolutely. Yeah. So usually, and I do pellets here in my office as well, I'm more in the, I guess, just mindset of educating my patients. And so I tell them about all of the options that are out there, whether it's a patch, an injection, a cream, the intravaginal cream or suppositories. Is it a troche, so a little capsule or a little tablet that's also on your tongue, or is it the pellet? And so I just give them the options, and the difference really is a lot. In terms of the data and what I know and what's out there is pellets sometimes tends to be in the first option because you do get a steady incline of those levels in your tissue. And then once you get to that therapeutic dose and the receptor maximizing content of that, then it's going to stay there. And so I like that better than an injection, for example. And maybe touching with like male patients now, right? A lot of them prefer injections, and they will usually do one injection a week. So you'll get a big spike of testosterone, and then it goes through the week, it will kind of come down, and then another spike. And so you get that zigzag effect in your system. And that also is super important in terms of evaluating how that's going to work in your physiology and your body. And so I prefer to have an option that's going to be more steady, developing the patient and creating that receptor exposure of the hormone versus a huge increase and then a drop.
Right.
Not to say that you can't get that with other treatments. With an injection, going back to testosterone, I usually recommend that nowadays there's a few studies that are supporting sub-Q injections of testosterone versus intramuscular injections.
Right.
And so maybe it's like injecting twice a week of a smaller doses of testosterone. So you get a more even sort of curve and you're staying here versus that huge spike. And the same thing with estradiol. In terms of the creams, they're great for a lot of patients, but they're tedious. I mean, you have to apply it every day. If you go traveling and then you're on a hot car in Arizona after getting to the airport and then they melt, and then now what happens? Or I forgot it in the hotel and then I don't have my hormone anymore.
Right.
So it can be complex in terms of the upkeep and really the longevity use of the cream, but also the risk of cross-contamination to our partners, pets, children, grandkids. And so that's another thing that I talk to patients. If you're in daycare and you're going to be applying it on your wrist or your inner arm in the mornings, and you're going to go take care of 10, 12 different little 2-year-olds that are going to be grabbing you all the time. Yeah, exactly. There's that risk. And so just knowing and seeing where the patient is, I'm always going to recommend my best option based on what I know on the patient and based on what we've tested. But at the end of the day, they are the ones that are going to have to be either injecting, applying, or getting the treatment. And so the end of the answer comes to the patient. The type of the treatment, it's important to know the difference for sure.
And that's that part of the personalized precision medicine. We're all, I think, ultimately going to be able to move to that based on genes, based on all these things in some futuristic. And now we've got things like hormone replacement therapy that can be so personalized and so precise with that special testing of the metabolites. It's just so different than just getting an LH and an FSH or getting a whatever.
Yeah.
So I think this is wonderful. I know that we've spoken on 2 of the major hormones at this point, and I know that sometimes ladies are placed on testosterone. You've talked about that. Does that also help with joint pain? Does that also help with the aches and pains? And does it help prevent skeletal muscle wasting that can potentially occur if you don't use it, you lose it as you age?
Yeah, no, great point. Especially with the muscle wasting. We already know that it's a risk as we age. And so testosterone has been shown to have a profound effect in the prevention of muscle loss, as long as you're also coupling it with a proper nutrition, proper exercise routine. So it's not that it's a fix for, I'm just going to sit at home and watch TV and my muscles are going to grow, but it's a matter of keeping up with these lifestyle changes. But yeah, testosterone is phenomenal. It's, in my opinion, one of the best hormones. It's so safe. even for males, we can talk about the risk of prostate cancer, and there's so much data. Urologists already recommend that even if you do have a prostate cancer, depending on the type of prostate cancer, a lot of them will even keep you on testosterone. But testosterone is a phenomenal molecule. I even recommend it to patients. And for females specifically, it's tough because there's not really a guideline that we can tell patients if you are less than 5, whether it's picoliters for whatever it is that we're measuring it, or if you're over this range, then you're considered hypogonadal or decrease or a true deficiency in testosterone. Whereas for males, it's very different.
Right.
We already know like less than 250, that's like clinically hypogonadal pathology and needs to be tested or treated. But it's so important. So we know, for example, looking at the data and over the years, if you look at 30, 40 years from now, testosterone levels in general in the population were within the normal parameters were a lot higher than they are now. So they were maybe between 60 and 120, 130 for females. And now it's like 0 to 50 or 55, depending on which lab you're looking at. And so what changed over the last 20, 30 years? Did we evolve that drastically in that short period of time that now all of a sudden our hormones have shifted and we don't need as much? In my opinion, it's not that. It's an important measure in looking at, well, what's your true optimal value based on your age, based on your gender and your sex, based on everything and other diseases that you could be carrying, where you should have that testosterone level. And so I would say the majority of my female patients, unless I'm seeing a young 28-year-old that's healthy and exercising and eating well, are going to be in that deficient, which is, I usually like to look at between 75 and 150. I mean, that's going to fluctuate depending on age and everything, but that's usually what I like to look at and keep patients in terms of the total testosterone production. And so that's one thing that I highly, highly recommend patients. And I've seen it work. I've seen that patient. I can recall a unique patient that came to my practice. She was 48 years of age. She came in with especially hip, low back, and bilateral knee pain for the last 6 months or so. She's already gone to a primary care. They've done the imaging. They've done blood work, even sent her to rheumatology. Nothing was working. She was still in a lot of pain and nothing was really working for her. So then we looked at her hormones and her testosterone was at 0, literally 0, which I've never seen. And so other hormones were fine, but testosterone was so low. So with just giving that testosterone replacement to that patient, and I'm talking within a week and a half, 2 weeks. And this is a very unique scenario, not to say that everyone is going to have this amazing result in this short period of time, but for her, it worked phenomenally. I'm talking about significant pain reduction to 0 to 10 within 2 weeks. She was able to have mobility. She was able to now work out and get out there and hike and do the things that she loved doing before all of this chronic pain and mystery, if you will, issue arose. And so it's just phenomenal what I've seen with patients.
Right?
Exactly.
And
I mean, literally
exercising, she's reducing her risk of cardiovascular disease and weight gain and metabolic syndrome and all these things. It's like, if you get to the root cause and treat what it is in the very beginning, you prevent that domino, the cascade effect.
Yeah, exactly. So it's just so phenomenal to really look at. And nowadays, I really try to empower my patients to truly be advocates for their own health.
Great.
And so if you are still wanting to use your insurance, you don't want to go the cash pay, that's excellent. But come up with a list of questions before you go to your appointment. Ask them, can you please test my hormones? What do you think about this? And if they don't know the answer, maybe it's a sign that you need to find somebody else that is more informative and actually is going to be taking care of you. And you have to do your own advocate. Okay. Yeah, absolutely.
Rather than fix me, I'm broken, which is kind of what the current medical model is, a pill for everything, but it's a maintenance of sick care. It's not well, and that you're advocating well care. And that's just wonderful. It's so empowering for people. So thank you so much for that part. I would like to switch to andropause because obviously males and females in our practice, and very similar things. I used to be the high school football player. I was able to coach all my kids' teams, soccer and football or t-ball. And now I'm to that point where I can't play with my grandkids and I have no energy and every single joint aches. I've got that. I hear that how many times a week. So it men too.
Absolutely. Yeah. And the hard thing with men is that we tend to be a little more stubborn and we tend to push it off, and we're not going to vocalize our issues that we're having unless our spouses or partners book an appointment for us. I mean, the amount of times that I see that, it's probably the most common reason that I see a male in my practice, because their extra or their +1 was the one actually called to set up the appointment. But it's so important to them as well, because same thing, andropause, it's going to happen to everyone at some point in their lives. I think in the years that I've been practicing, I maybe seen one patient that's like 72 and its testosterone physiologically is like 780, 800 usually, which is like, I've never seen that. But the majority of my patients are not that. They're usually low 200s, 300s even. And so that's where also the difference between care is so important, because if you go to your point, the conventional MDDO that takes insurance and goes that route, they will test it maybe. I mean, that testing, it's usually not a problem. However, deciphering it, where that number lies, where do you fall under that normal, is important. So maybe you're like, let's say 280, 300, and you have symptoms. You're not sleeping, you're having weight gain, you don't have to drive anymore to go to the gym, you're not recovering after your physical activity. Obviously, libido can be impaired. Your sexual drive and function is not there anymore. And so then they say, well, it's still normal and your insurance is not going to cover a replacement therapy. So let's order, maybe they'll retest in a couple of weeks again. And let's say it's even there or maybe a little higher, because now you're like, okay, well, maybe I should start working out a little more. So let's say it goes up to 350. And so now, like, well, yeah, absolutely not going to be covered. You definitely don't need it. It's improving. Keep doing what you're doing. But it gets to a time where we can only do so much in terms of our environment and what we can have control on, whether it's working out, proper nutrition and diet, sleep, and everything that we touched about before. After a certain time, we need to have that potential of extra support from that hormone component. And so for me, honestly, if they're symptomatic, and I see the results of maybe a couple of times that we repeat them and they're under 500, I will most likely start having the conversation about a replacement therapy for testosterone. And the age is going to be very dependent on that as well, because I've seen some 28-year-old guys that are having 150. It's like, what is going on? Yeah. And so for them, we have that conversation of maybe do we start you on a medication like Clomid that's going to be working more in that brain connection between your brain and your testes to make sure that you have that proper stimulus and autologous or physiologic production from your own body before we jump into a full-on testosterone replacement, because it is important to have that conversation. Once we start, especially for males, a testosterone replacement, I tell them it's for the long haul. It's not just like a short term, I do it for a few months, I feel awesome, now I'm going to be off of it, because your body is depending on that new delivery of hormone that it wasn't getting from your own body before. And so it's a long-term treatment. It's not a short-term treatment. It's a commitment. It's a financial commitment. It is important to have those discussions with our patients as well. But I think once you put that all into perspective, and going back to the whole lifespan and health span, and I'd ask them, where do you see yourself in 30 years, in 40 years, in 50 years? Do you see yourself still able to drive yourself to the grocery store and being able to walk without a walker or a cane and buying your own groceries and getting things off the shelf? Is that a thing that matters to you? If it does, then we need to start making these changes, because this is how we can get you there. And if it's not important, then quite frankly, it's a different conversation that we should be having. But yeah, I mean, that's super important for males as well. And having that discussion and that early talk with your provider. Don't be afraid of asking them if you are experiencing those symptoms. It doesn't hurt to get tested and make sure that it's not that piece of the puzzle, and being able to get that benefit if it is part of that.
Like with ladies, if you're using testosterone, it's not going to be the magic thing where you sit on the couch and just building muscle. So it's another commitment to, you're committed to your health span. You're committed to this for the long term, not only the financial, but also the fact that you're going to add in the anti-inflammatory eating. You're going to add in the resistance training at the gym or at home with your own home gym, but you are committed.
Yeah, no, absolutely. Yeah. And going back to that issue of muscle wasting, testosterone plays a tremendous role in the proper maintenance and even in some cases, potentially the reversal of things like osteoporosis, which we know they go hand in hand. The weaker we are, the more fragile and frail our bones are going to be. And so the better strength, the better muscle activity that we have, the better results we're going to get on that end as well. And so, yeah, having that conversation as well is super important. And also the options is not that, for example, men can get pelleted. And I do it and I recommend it, quite frankly, because they forget on the duration of the pellet, especially the pellet that I use, the company that I use can last up to 8 months, for example, on male patients. So they only come once a year. Realistically, they get the procedure. Sure, they have a downtime of 4 or 5 days of not going to the water, not doing heavy lifting and twisting just to protect the site. But that's about all that they have to do. And so that's,
or every 2 weeks, twice a week doing sub-Q or whatever we're talking about, that, you have to weigh that. It may make you more compliant.
Yeah, exactly. Yeah. And some patients that I've seen that come from a pellet past, some of them have had bad experiences, really depending on, unfortunately, is very practitioner and very provider specific on their technique. And so the way that I do it on my male patients is actually in the flank. Why? Because that's where they tend to have the majority or the most part of fat or subcutaneous fat versus the upper glute on females. And so knowing that and going above the belt for the patient, it's so much more comfortable. They don't have to have that issue of extrusion, which is a known risk of pellets where they can literally pop out of your skin because your body, it is a foreign object. Your body can reject and it can extrude, but it significantly reduces the risk of that by doing it that way. And with my musculoskeletal background, occasionally I like to throw my ultrasound on that site. And I like to just double check that my insertion is into that subcutaneous fat area. It's not in the muscle. And I know just that extra layer of caution and precision, to your point, that I think it's so important and patients really appreciate.
And absolutely, because it's going to affect their ability to work out if it's in the muscle and they could extrude. So, wow. So, like women, is there a certain amount of years that you've been in andropause that you won't want to start testosterone therapy?
Yeah, usually for male, I tend to see it a little bit earlier. I would say I'd recommend everyone to really get tested at 40. Obviously, if you're symptomatic, maybe a little bit earlier, maybe a little bit later, but just basic kind of screening, especially for longevity purposes, I would say 40 is a good time to start getting tested, as you also start talking about prostate screening, prostate cancer screening, colon cancer screening. I think it's just one of those things I usually recommend as an extra sort of screening tool for patients because it's so valuable for patients. And even something that I've seen that I also find interesting is the risk of, for example, marital issues and marital divorce. And I recently saw some numbers that show later on adulthood, 38, 40 years old, the risk literally spikes by more than double of where it is in some earlier years. And so I wonder if it's because they're going through the shifts of changes in their hormone, both male and female or other partners. And so is that part of what's also going on? And so if we also look at it that way, and if we target that as well, and we get you optimized, and that could potentially also help with minimizing that sort of at-home potential dilemma and issue that could be happening. And so it's just something to consider and something that I've seen a little more over the last year that I think is just interesting. Maybe there is a true relationship there.
I don't see why we couldn't connect those dots. That's interesting.
Yeah.
Is there an age at which you would not start? If a person has not been on, he's now 65 and now he's starting to get the aches, and I'm sure there is osteoarthritis in the knees, there's probably some in the shoulders, there could be a lot of stenosis in the spine. Is it something that's too late to start? replacement testosterone?
Not really. Honestly, for testosterone, it's so safe, even for males and females. Maybe you can be a little more conservative with your dosing instead of getting them to 900 or 800 or whatever it is that I think that the value should be for them. Maybe we start in at 600. It really depends on the patient and where they are and where they're going to feel. And that's something that I also see a lot with my patients that are coming from other practices, is that they tend to, some providers tend to be so focused on the lab and like, you don't fit in this little box, perfect lab work. Let's change your dosing. Let's change your medication. Let's change your supplements to get you there. But are they feeling okay? Are their symptoms back? You're treating a patient, or you're not treating labs. And so why would we shift the patient's treatment if they're responding really well to the treatment at that dose? So some people, but going back to hormones, can perform and do phenomenally at 500, but they started at 100.
Right.
And so they don't need to be super physiologically dosed to get the same effects. And so there is that art of hormone replacement, if you will, of really linking that connection and talking to your patients and seeing where they are. And it doesn't necessarily have to be at the perfect lab. It can be a little bit off, but as long as they're getting better, as long as they're getting the results that they're looking for, why do we need to change it? So.
And you've got somebody like you who is trained to know the right questions to ask, has the ability in their practice to spend the time and get to know the person, and can then make these tiny little tweaks and continue to precisely make this that precision therapy that is going to take the patient into a healthy future. So I think that's a big part.
Absolutely. Yeah.
I think this has been fabulous. I really appreciate it. Is there something that we did not touch on that you think we absolutely must tell the listeners?
No, I mean, I think we hit some really, really great points. Just a quick summary: get tested early. If you're symptomatic, go get tested. If you're not getting the care in your provider where you should be getting, find someone else that's going to be taking care of you. Don't be afraid of it. There's tons of data, tons of research supporting the benefits of especially bioidentical hormone replacement therapy on people. And it could be the answer for you. It doesn't necessarily have to be something else. So just recommend to really stay open and get the answers that you need.
How do people find you? How do they follow you? What kind of socials do you have? Because I'm sure you're going to have a lot of interest after that.
Yeah, so they can find me on my website, which is modmedaz.com. So modmedaz.com. They can book directly through our website if they're interested. I always offer a free 15-minute meet and greet, if you will, or anyone that's curious to see if my approach would be a good fit for them. They could always find us as well on our Facebook page, which is Modern Medicine AZ, and then on Instagram, ModMedAZ. TikTok as well, ModMedAZ. Nowadays, we have to be on everything. Yep. And I do have a YouTube channel as well. I'm going to start being more active. Actually, we're working on some great things there. And so that's also Modern Medicine AZ, how they can find us.
Wonderful. So we will definitely link all of these in the notes below, I promise, if you weren't so quick with the pen. Dr. David Gallegos, thank you so much. Hormones absolutely can play a role in joint pain, in spine pain, and getting those optimized and getting you back to those levels may just be that thing that takes you to the next level and keeps you active. So thank you so much for your time.
Thank you for having me. This is awesome. Thank you so much.
My pleasure. Take care.
If you have knee pain and would like to learn more, I have a worksheet called 5 Things to Do Now to Reduce Your Knee Pain Within a Week. Go to www.kneeboostnow.com to download it for free. I'd love to hear from you, so please like, subscribe, and comment below so I can help you get out of your knee pain.